I would like to welcome you all to the 19th Shaukat Khanum Cancer Symposium, which is held in collaboration with ESCO, and this is one of the biggest oncology meetings of the region. As we are all aware, this year has been exciting in many fronts, whether it is pandemic, which helped us in changing the way we treat our oncology patients, or it is yesterday's Pennsylvania County results, or we talk about gastrointestinal and hepatobiliary cancers. Many pivotal abstracts and key clinical trials were presented this year in different international meetings. And now more than ever, we are witnessing improvements in survival and quality of life as we continue to manage our patients and the way our management is evolving at all fronts, whether it is surgery, systemic therapies, or radiation oncology. I am Dr. Tabenda Sadaf, GI oncologist at Shaukat Khanum Memorial Cancer Hospital, and I am joined by my co-host, Dr. Syed Irfan Kabir. He's a hepatobiliary surgeon working at Shaukat Khanum Memorial Cancer Hospital. We have an incredible faculty today with us from all across the globe, and I would like to thank personally each and every of my participants and speakers for taking their time out and showing this commitment despite all these difficult times. So for next 3 hours, I would request all the participants to grab their cup of coffee because we have exciting line of lectures lined up where we will be talking about widespread multidisciplinary management of all cancer aspects in colorectal cancers, gastric cancers, and hepatobiliary cancers. I would like to introduce to my faculty for the first session, which is Dr. Uqba Khan. Dr. Uqba is assistant professor. Dr. Uqba is an assistant professor at Cornwall Brooklyn Methodist Hospital and a gastrointestinal oncologist. Thank you very much, Dr. Uqba. We all know that the timings were very odd, but you stood up to your commitment. Thank you for joining us. And today he will be talking about management and updates in gastric cancer. And he will take us through the new data that was presented this year and how that data has shaped the management of gastric cancer treatment in our clinics. Dr. Uqba, it's over to you now. Thank you very much.
All right. Thank you very much for the kind introduction. I hope you can hear me.
Yeah.
So let me share my screen, first of all. Just want to make sure you can you see my screen, please?
Yes, we can see it very clearly.
All right, excellent. So I think this is my first meeting where I can say good morning and good night at the same time because it's midnight here in New York. But I'm very grateful for the invitation from the organizing committee. So today I will be talking about updates in the treatment of metastatic gastric cancer. So I don't have any disclosures. So agenda of this talk is basically to discuss about the recent updates in systemic treatment of gastric cancer, specifically the checkpoint inhibitors that we currently use in this setting. In addition to that, I will be talking about the biomarker-driven treatment of gastric cancer and the newer targeted therapies and some of the exciting ongoing clinical trials. So let's put things into perspective. This chart gives you an idea about how far we have achieved in the field of oncology in the last 30 to 40 years. If you see in the right top corner, you can see we have made good strides in improving the outcomes of patients like prostate cancer, thyroid malignancy, melanoma, and breast cancer. But on the bottom left side, unfortunately, these are the tumors where still there's a lot of room for improvement. And one of the cancer you can see is the stomach or gastric cancer, where the overall survival is still not good. And in fact, most of the tumors you can see on the bottom left are GI malignancies, with the pancreatic cancer the worst one in terms of the outcomes of the patients. So talking about the gastric cancer, just briefly, as you know, it is the second leading cause of cancer that globally, and there is a disparity in the incidence of this cancer worldwide. We don't see it that often in the United States, where there's only about 27,000 cases per year with 11,000 deaths. And on the right side, you can see this graph in the Asian countries, especially Korea and Japan, have high incidence of gastric cancer. And unfortunately, the survival is still very poor, with a median overall survival of 1 year in advanced or metastatic setting. But we have done quite a work in the recent past, specifically in the last decade. And one of the pivotal studies that have been done is in the molecular classification of gastric cancer. This is the TCGA data that was published back in 2014, which classified the gastric cancer into four major categories, with EBV positive tumors, MSI high tumors, genomic stability, and CIN chromosomal instability. And depending upon that molecular classification, we can find targeted therapies. And based on that, there are new treatments that we can utilize in our clinic based on the molecular classification. So let's talk about how we select patients to treat gastric cancer in advanced setting. And this is more of a historical way of treating. But regardless, first thing is we check the biomarker, and one of the most important biomarkers is the HER2 status. So if the patient with advanced gastric cancer has HER2 positive disease, we usually treat that patient with combination of chemotherapy that could be FOLFOX or cisplatin plus 5-FU, in addition to trastuzumab. And if the patient progress on that treatment, depending upon the performance status of that patient, we proceed with the second line of treatment. And the second line treatment standard of care is either paclitaxel or paclitaxel plus ramucirumab. Similarly, if the patient doesn't have HER2 positive disease, those patients are typically treated with doublet chemotherapy agents like platinum 5-FU or FOLFOX. And if they progress on that, you can start the patients on either paclitaxel or a combination of paclitaxel with ramucirumab. The whole idea of treating a patient with metastatic or advanced gastric cancer is actually palliation. And there's obviously no cure for that. And you just have to make sure you balance the toxicities along the treatment. So you have to take into account the age of the patient, functional status, and the comorbidities when you are choosing a systemic treatment. And generally speaking, patients actually, we prefer doublet chemotherapy for most of our patients. But if the patient performance status is poor, we can do a monotherapy like 5-FU or capecitabine or even a taxane in elderly poor performance status patients. But if the patient is young with minimal comorbid condition, we can consider a 3-drug combination of chemotherapy incorporating the taxane along with 5-FU and a platinum agent. But what have we done over the last few years in addition to chemotherapy? This is the therapeutic landscape of the recent updates or the approvals of medications in advanced gastric cancer. And here you can see that in 2010, that was the first targeted therapy that was approved in gastric cancer, that was trastuzumab. Later on, 4 years later, we had approval of ramucirumab with or without paclitaxel in second-line setting. And then 2017 and later on, there were a few more approvals, including the checkpoint inhibitors, trifluridine and tipiracil in third-line setting, and then the tissue-agnostic approvals, including the pembrolizumab in MSI high tumors, NTRK fusions with the approval of larotrectinib and entrectinib, and most recently tumor mutational burden of 10 or higher, we have checkpoint inhibitors. And obviously, FLAUT has been widely used in perioperative setting. So there has been quite some improvement especially in the systemic treatment of gastric cancer, specifically in the last 5-8 years. So let's talk about specifically about the checkpoint inhibitors in third line setting. So about 3 years ago, this trial was done, which is a Keynote 059, which was a phase 2 study of pembrolizumab in gastric and GE junction adenocarcinoma. It was a multi-cohort, non-randomized clinical trial. And one of the cohort of this study was cohort 1, which was patients who had used 2 or more prior lines of chemotherapy. They were given pembrolizumab until progression. And this clinical trial showed us that pembrolizumab has activity in gastric cancer. Although the response rate was very modest, or very low actually, about 11.6% in all patient population, but patients who have PDL1 of 1 or higher, their overall response rate was about 15 or 16%. But there were many patients who had stable disease on pembrolizumab. And on the basis of this data, pembrolizumab was approved in third line setting in gastric adenocarcinoma with a positive PDL1 score of 1 or more. And it is currently being used as a standard of care in third line setting. Similarly, nivolumab also showed activity in third line setting. It was an ATTRACTION-2 study that showed benefit over placebo in gastric and GE junction adenocarcinoma. And you can see on the left side with this Kaplan-Meier curve that nivolumab clearly showed benefit. So therefore, nivolumab can certainly be used as well in addition to pembrolizumab. So moving along in second line setting. So there have been few trials in second line setting as well. So this is one of the pivotal trial, Keynote 061, a study in which patients with adenocarcinoma who had progressed on first line of therapy were randomized to pembrolizumab versus paclitaxel. So you can see that the control arm is paclitaxel, and the criticism for this trial was that the paclitaxel was not a good control arm, because as you know, paclitaxel plus ramucirumab is actually the standard of care. So they did not use the right control arm. But despite using not the good control arm, pembrolizumab did not show any benefit over chemotherapy. And you can see on this Kaplan-Meier curve, one of the problems with immunotherapy is that there's a significant drop in either progression or patient deaths early on if they are on PDL1 inhibitors. So it was a negative trial. It did not show any benefit of using pembrolizumab specifically in CPS of 1 or greater than 1. Then there was another study, Keynote 181, which was done slightly different in a different patient population. In this trial, the key eligibility criteria was advanced or metastatic adenocarcinoma or squamous cell carcinoma of esophagus, Stewart type 1, or GE junction. But they did not have any patients with pure gastric cancer. And they were randomized again into pembro versus chemotherapy of physician choice. The overall survival from intent to treat showed some benefit of using pembrolizumab compared to chemotherapy. But when they looked into subset analysis, specifically the squamous cell carcinoma, there was clear benefit of using pembrolizumab compared to chemotherapy. And further, in key subgroup analysis in terms of overall survival, you can see patients who had high PD-L1 score of 10 or more than 10, and if they have squamous cell pathology, they were the patients who really benefited from the pembrolizumab. So on the basis of this clinical trial, pembrolizumab was approved in second-line setting, but in squamous cell carcinoma with PDL score of 10 or more than 10. But it is not yet approved in adenocarcinoma because of not much improvement in survival. So what about a first-line setting? So we learned about the third-line setting, second-line setting, and a lot of clinical trials have been done in first-line setting. Keynote 062 was, I believe, presented last year at ASCO. This was very complicated clinical trial. As you can see in this patient population, patients who had adenocarcinoma, HER2 negative disease with PDL1 of CPS of 1 or more were randomized into 3 different arms. The control arm was chemotherapy. The investigative arms were either single agent or monotherapy pembrolizumab or pembrolizumab plus chemotherapy. And those 2 arms were compared to chemotherapy. They were not compared to each other. And this slide showed the statistical considerations of this trial. It is very cumbersome. I just wanted to show you, just to give you an idea how complex it was, because they compared multiple steps in the statistical analysis. Some of them were non-inferiority, some were superiority, so they had to adjust their p-value accordingly. So anyhow, when they compared the pembrolizumab with the chemotherapy in the first-line setting with CPS score of 1 or more, it was a non-inferiority trial. It showed that there was pembrolizumab was non-inferior to chemotherapy. But again, the problem was, if you look at the left side of this graph, the Kaplan-Meier curve, that there was a rapid drop in the patients who progressed quickly on pembrolizumab, and which is not acceptable. So patients who were initially on chemotherapy did well, but later on, you can see there's a curve of the tail of the curve, which represent that if the patients who respond to immunotherapy, they do well overall, but if the patient do not respond well, there's a rapid progression of the disease early on. So therefore, pembrolizumab was not approved in the first-line setting based on this data. Similarly, within this trial, they looked at the combination of pembrolizumab along with chemotherapy versus chemotherapy in CPS score of 1 or more than 1. It did not show superiority of combination of pembro with chemo versus chemo alone. So again, this was a negative trial, statistically speaking. So based on the basis of that, the FDA hasn't approved pembrolizumab in the first-line setting. However, this year in the ESMO, there was new data that was presented, which was Checkmate 649, which was a clinical trial of chemotherapy with or without nivolumab in first-line setting. It was more of a cleaner clinical trial in advanced gastric or G-junction adenocarcinoma with HER2 negative disease. And there were 3 different arms of the study. One arm was nivo-ipi, which hasn't been resulted, but the other arm, which was compared to each other, was chemotherapy, which either FOLFOX or XELOX, versus chemotherapy plus nivolumab. And the primary endpoint was dual OS and PFS. And this study clearly showed benefit of using or adding nivolumab to chemotherapy. And you can see on the left side the overall survival in PDL1 CPS score of 1 or greater than 1. The 1 year overall survival rate was 56% versus 47%. And in all randomized patients, there was still a benefit of using pembrolizumab with a very good hazard ratio and very low p-value, which was statistically significant. So I hope that this positive trial may lead to the approval of nivolumab in first-line setting, but it's yet to be approved. So what about using other biomarkers like MSI high tumors? So what is the role of immunotherapy in MSI high gastric cancer? As you know, MSI high is present in very small number of gastric cancer patients, but if you do find it, patients do have a very good response rate and a prolonged response to the immunotherapy. So in the first line setting, this data is from the first line trial of Keynote-062, in which immunotherapy was compared to chemotherapy. And in the subset analysis, what was found out was that patients who were treated with immunotherapy had a very good response rate and a very good overall survival. And you can see that patients with the CPS score of 1 or more, the 12-month survival was close to 80% compared to 47% in the chemotherapy arm. And even CPS more than 10 was also very high. So on basis of this data, I think immunotherapy can be used in the first line setting if the patient has MSI high tumor. What about tumor mutational burden? Recently, FDA approved checkpoint inhibitor pembrolizumab in the chemo-refractory setting if the patient has high tumor mutational burden. There has been some controversy in terms of defining the tumor mutational burden and what is the cutoff for high mutational tumor mutational burden. But anyhow, FDA used a cutoff of 10 or more because this was based on a trial called Keynote-158, where different tumors were treated with pembrolizumab, and they compared with low tumor mutational burden versus high tumor mutational burden using a cutoff of 10. And they looked at the response rate, I believe, was about 40 or 43%. And based on this data, FDA approved pembrolizumab in this setting. So certainly it can be.
Upa, we have 2 more minutes, please.
Sure. So I'll be quickly finishing off. And this is just the summary of the checkpoint inhibitors in first line setting. As you know, it's not yet approved, but hopefully it may be approved sooner. But second line setting, you can use in squamous cell carcinoma, and definitely third line setting, you can use pembrolizumab. What about in HER2 positive disease? There are a number of drugs that are currently being tested. There are no approvals yet in third line or actually in HER2 positive disease. But I just want to quickly touch base with you regarding this important trial, Destiny Gastric 1 trial, which used trastuzumab deruxtecan in third line setting. And it showed some promising results in terms of overall survival. And this drug is moving forward in the first line setting. And hopefully with the positive phase 3 trials, I hope trastuzumab deruxtecan can be approved in this setting. This is another ongoing clinical trial of using pembrolizumab with trastuzumab It's an ongoing trial. It's accruing patients, and over the next few years, we will get some results. And these are some of the exciting clinical trials that are ongoing, phase 2 studies and phase 3 studies, specifically using some of the novel agents like VEGF TKIs, FGFR2 antibodies, anti-Claudin 18 inhibitors, along with chemotherapy. They are in their late phase of clinical trials, and hopefully in the next 1 to 2 years, we may hope that we have good results from that and more approvals. So, so just quickly, this is my last slide. So take-home messages. So treatment should be driven by predictive biomarkers. All the patients who you diagnose with advanced gastric cancer should be tested for HER2/neu, MSI, tumor mutational burden, PD-L1, and NTRK fusions. And it can be best done with next generation sequencing. Checkpoint inhibitors are currently approved in third line setting, but if the patient have MSI high tumors and tumor mutational burden high, checkpoint inhibitors can be used in early lines of therapy. And there could be approval, likely approval of checkpoint inhibitors in first line setting as well. And there are several ongoing clinical trials that are promising, specifically trastuzumab, deruxtecan, margetuximab, and combination strategies with pembrolizumab and other checkpoint inhibitors. So with that, I finish my talk, and thank you very much. I may not stay for the Q&A session because I have to go to bed and sleep, but this is my Twitter handle and my email address. Please feel free to email me any questions or any concern regarding your patients. I will be very happy to answer any of your questions. So again, thank you very much.
Thank you very much, Dr. Okba. It was a very, very informative talk. And actually, we learned a lot from this. If we have any questions, I'll post you later on, and then maybe I can get the answer and get back to the participants who are there. And we are really sorry for keeping you awake this late, but have a good night's sleep. Thank you very much.
All right. Thank you. Thank you for inviting.
So now moving on to the next program, our speaker, we all know that over the last few decades, the role of hepatobiliary surgery in hepatobiliary oncology has significantly expanded, and that mainly may be attributed to early representation of the diseases and increase in systemic therapies, which has led to the improved survival in these patients. And then they do pretty well, and the role of hepatobiliary surgeon is very important in later stages of metastatic disease as well. But in our country and in our scenarios, we still have paucity of availability of a trained hepatobiliary surgeon and hepatobiliary oncology training programs. I would like to invite Dr. Syed Irfan Kabir, who will highlight the training program of hepatobiliary oncology in Shaukat Khanum. What are the caveats and what are the plus points, and how can we improve this program further? Thank you very much, Dr. Irfan, and now it's over to you.
Dr. Tabinda?
We can see the slides.
Okay, perfect. Right. Yeah. So good morning, everyone. I'm Syed Irfan Kabir. I'm consultant hepatobiliary surgeon here at Shaukat Khanum Memorial Cancer Hospital. And I'm going to talk to you about HPB oncological training at SKM. And I'm going to take you through along with me in the journey that we've had so far. Now, all medications are helpful in treating cancer. However, the most important thing in improving outcome is to make sure that the future generation of surgeons are well trained in providing surgical oncology. So this is going to be the agenda today, and I'm going to follow in this sequence. The first thing we need to talk about is what's the actual disease burden in Pakistan. Do we actually need hepatobiliary surgery as a specialty or as a service? In this diagram, you can see Pakistan is in the blue. That basically means the incidence of disease burden for liver cancer is 4.9 per 100,000. We've got a population of 212 million, and the prevalence of colorectal cancer is 4 to 8%. We've got a 5% incidence of hepatocellular HCV virus. 60% of these patients are going to go on to get HCC cancer of some sort. So this is a huge burden here. And most of our patients are young at presentation. When it comes to pancreatic cancer, we do not have any countrywide database. There are individual provincial and institutional databases such as the Shaukat Khanum database, the Aga Khan database, the Punjab Cancer Registry, but the actual countrywide incidence is not known. What we do know is that in the last 1 year, we've done over 80 pancreatic resections of various sorts. That in itself tells us that there is a big disease burden out there for pancreatic cancer as well. Only 20% of pancreatic cancers when they present are operable based on Western data. So there's a huge number of patients out there who got pancreatic cancer and may not be amenable to surgical therapy. Over the years at Shaukat Khanum Hospital, our workload has gone up. We were doing 26 resections back in 2015, and we did about 57 resections for Whipple's, which is known as the pancreatic duodenectomy as well. This year it's been 57. So what are the barriers to surgical care in Pakistan? Again, we are in the red here. You can see in the map here. Most of the European countries are in the pink, which means they've got good access. Most of the countries around this area are in the red. And this is red for access to basic surgical services. If I were to talk about access to oncological surgery, we would probably be in the black because there's not enough trained surgical oncologists in the country. Multiple factors to barriers of care in Pakistan. I'm not going to go into detail about all of this because it's outside the scope of this presentation. However, I will take your attention into this corner here, the provider level factors, and we're going to talk about the knowledge and skill as well as healthcare provider aspects of things. So the first question that arises is, do we have a deficit in training? That's the first question that comes to mind. Do we actually have a problem? This study from America in 2013 showed that 30% of their residents are not confident in doing laparoscopic cholecystectomy at the end of their residency program. But what's more interesting is that 30% of those who think they can perform it independently, their supervisors have other ideas. So this also shows that there's a lack of insight into abilities. And this is from a very well-established training program in America. Similarly, when these residents go into fellowship, 38% of fellows do not take ownership of their patients. And this is from their program directors. So again, there's an issue in training in places like America. So with that in mind, we want to know if we have a problem over here. Do we have a problem in our training system? So we did this survey of all the residents and fellows who come to Shaukat Khanum for training. And this is based on their experience before they joined us. And as you can see here, almost 25% of respondents had no exposure to open cholecystectomy. And there was some who have had very brief experience of less than 10 cases. Only 35 to 36% of people felt confident in doing open cholecystectomy independently. When it came to laparoscopic cholecystectomy, that independent factor actually dropped from around here to 30%. And the no exposure and the most assisting part of this graph has gone up. And when we talk about more complex surgery, such as Whipple's procedure, it's actually white here, no experience, and hardly any exposure for around 40% of the respondents. In liver surgery, it goes up to 70%, and this drops. And when it comes to laparoscopic liver resection, most of this graph is blank, and I don't need to explain this at all. The issue here is that when we do complex surgeries, we want to know that our residents and fellows are able to pick up on the complications early on, because time is crucial in these patients. And this graph shows that almost 48% know only basic stuff about the management of complex pancreatic resections. And that is worrying. And that's what we wanted to change with our training program. This is based on all the fellows who've completed their residency program from outside. And again, the problem arises on around 35% don't feel confident doing open cholecystectomy, laparoscopic cholecystectomy, and so forth. So we do have a problem with our training system in that, and there are multifactorials. You know, there's lack of access to the equipment. It's a complicated surgeries, and we've got other disease burden to deal with in outside of SKM as well. So it's multifactorial. However, we wanted to change that. So we looked at various training models which we could imply here. We looked at the old traditional see one, do one, teach one model, which is the mentor apprenticeship model. We looked at the German model, in which we start off with no responsibility, and as you go up the pyramid scale, you get more responsibility. And we looked at the mall model, which is like, let the trainee get on with it, and if they get into trouble, they can call you, otherwise they can learn by themselves. And this is a kind of a self-teaching kind of model. We've all been here as surgeons, middle of the night, about to start an operation, no clue what to do, and looking up this general surgical atlas to decide on what to do with that patient who's in front of us. Some of us look at YouTube videos to learn how to operate, to learn tricks of the trade to do complicated surgeries or simple surgeries for that matter. The problem with that, as this study shows, that almost 70% of videos for laparoscopic cholecystectomy on YouTube were considered unsafe, and some were actually dangerous. So this is a kind of a blind leading the blind scenario where we're trying to learn from people who may not be doing it correctly themselves. So there is a need for training. Why is training difficult? It's difficult because it's complex. It's not a linear relationship. Don't go into the details of these things, but what you actually need for good training is a mentor who's committed to training the trainee, and a very ambitious and a dedicated trainee who's willing to put in the time and effort for it. It's doable. In England, they introduced a national training program for laparoscopic colorectal surgery. And I think it was in Holland that they introduced the LEPR 2 trial, where they introduced laparoscopic distal pancreatectomy into their surgical training program. And these two studies shows that training is possible, even though it's complicated surgeries. So the training program that we wanted to inculcate here, we thought should give these competencies to our trainees. They should be patient-centered, they need to be organized, professionalist, and they need to have good leadership skills. But they also have to have surgical skills. They need to assist. They need to operate both under supervision and independently. But more importantly, they must have a knack to teach their junior colleagues. And that is important. So we came up with this obstacle targeted education or result oriented education. And the main emphasis is not on motor skills. Our trainees, when they come here, have got enough exposure to general surgical procedures, but we don't want to teach them that. What we want to teach them is psychomotor skills, because a skilled operation is 75% decision making and only 25% dexterity. And that's what we want to get across to them. Psychomotor skill is not equal to motor skills. And this is what we want them to follow. This is where we get a trainee. We want them to conceptualize the operation. And this is where we want to take them to. But the journey doesn't end here, because it's a continuously evolving process, and they have to get continuous feedback, and they have to kind of audit their practice to see how they're doing and continuously evolve as a surgeon. The trainees have responsibility as well. It's not just the trainer's responsibility. The trainee has to come prepared to theater. They have to know the operation, conceptualize what's going on. They have to visualize the steps, and they have to be able to verbalize the steps, because that tells us as trainers that this person understands what's going on and he's ready to do these procedures. So when they first come to us, we have a meeting with one-on-one with them, and we ask them where they are and they would like to be and what they want to learn. And then in the first 2-3 weeks, we get them to just observe the steps of the procedure, because they are complicated surgeries and they need to know what's being done. The question then arises is it safe for the patients to have training provided in complicated surgeries? This study shows actually residents are as efficient in doing an operation as their consultants, and the complication rates are no different. In fact, I think they're less. That does not mean that the new trainees are better than their consultant colleagues. It just shows that the trainer has been able to identify the skill set of the trainee, and he has been able to identify the caseload appropriate for that training skills. So what is appropriate in pancreatic resection? So if we had a trainee, we would like to have a thin patient, we would like to have a large bile duct, we would like to have a hard pancreas and a dilated pancreatic duct. Now, this does not reduce complication rates completely to zero, but it does help in reducing the complication rates, and therefore it's an appropriate training case. Lots of consensus on training, and all of them basically say the same thing. You need to have experience in open surgery. You need to have experience with laparoscopy. It has to be stepwise, and you need to constantly audit your results. This is not numbers needed to treat. This is number needed to train. Now, we know there's a problem. We know we've got a system in place. Do we actually have the numbers to train our fellows and residents? And across the years, the numbers have been quite similar, but I've just taken 1 year's numbers here. We've done quite a significant number of pancreatic resections, around 57, and around 47 liver resections, along with other things. So we do have the numbers. When I compare this to most of the centers in the UK, we are doing similar, if not better than some of the intermediate level centers. Now, having good numbers does not mean we're doing good surgery. So we have to benchmark our outcomes before we teach somebody else. And this paper in the Annals of Surgery benchmarks the outcomes for Whipple's procedure. And when we compare our results to those benchmarks, we're actually doing okay in terms of our duration of surgery, in terms of our length of stay, in terms of ITU stay. I must say our infection rates are a bit on the higher side, but there are multifactorial reasons for that. I won't go into the details of that because that's a subject of another study. Our lymph node yield is actually really good, it's 22, whereas the accepted is 16. Now, if you want to compare two HPB units together, you look at the lymph node yield. And this basically tells us that we've been quite radical with our surgery, so that's pretty good. Our resection margin is 96%, and I think that's more to do with the type of patients we get here, because we get mostly periampullary cancers rather than pancreatic per se, and therefore our node resections are quite good. So we meet the standard for pancreatic surgery. Do we do the same for liver surgery? And yes, we do. Actually, our results are pretty good. So we've got the numbers, we've got a problem, and we've got the standards. So we go on and make a team, which has been kind of going on in SKM for quite a long time. We've got about 2 residents which have done which are doing their FCPS training. We have 1 or 2 fellows which are finished their FCPS and they're looking at oncological surgical training. We have a senior instructor who's finished their training and they want to become independent. And we've got 2 consultants. Prior to me joining here, it was Dr. Amir Ali Sayed and Dr. Faisal Hanif doing hepatobiliary. And now it's Dr. Amir Ali Sayed as the senior colleague and myself having joined last year. So we've got a good team going on here. And we've got 3 full theater sessions and clinics a week. We have a multidisciplinary team meeting in which it's mandatory for the trainees to come. They have weekly lectures and research is a mandatory requirement. And this is in keeping with all the requirements from the various associations across the world. We do not have exposure to transplant surgery. And the reason for that is that we are a purely oncological center. And for oncological HPB, exposure to transplant is not mandatory. So we don't provide that, and because our requirements are different. So with so many people in the team, how do we find a balance? We do that because we have a competence-based training. It's not seniority-based, it's competence-based. We appreciate that everybody's got different needs and the progression is over time. So everybody progresses in their own time. You can't rush learning. Everybody that learns has to teach. That's mandatory. And they must have insight into limitations. This study from Rochester Mayo Clinic shows that with a good case mix, residents and fellows do get along and they both benefit from the training program. So how do our trainees progress? So when they join us, we assess them on cholecystectomy first. We take them to various parts, which is initially supervised, and then they become independent and supervised. And at the end, they have to supervise their junior colleagues. That's mandatory. For pancreatic resection, we've divided into excision and reconstruction, and we take them supervised in each step as we get along. And as they become proficient in each step, they move on to the next step. So it's competence-based training. We make sure that they write the op notes, because that tells us as consultants that the trainee understands what he's done in the operation. And we definitely have to get them to speak to the relatives and the patient in the post-op setting, because that shows empathy and it gives confidence to the relatives and the patient that they're being looked after. And this is important because without empathy, you cannot be a good surgeon. And we have to inculcate this into our training program. Similarly, for liver resection, we do a stepwise approach. And most of the time, the trainees get to mobilization of the liver, and that's important for general surgery. So I'm just going to give you a few snapshots of one of our fellows residents doing a cholecystectomy. He is mobilizing the gallbladder. Here he's dividing the anterior wall of the gallbladder peritoneum. Then he's made the window of safety. He's clipped the bile ducts, and then he's taken the gallbladder off the liver. Similarly, for liver resection, apologize if people are squeamish. A fellow is doing the ultrasound of the liver. This tells us what the vein, where the veins are and where the lesions is. Then we mobilize the left lobe of the liver. Then we divide the liver. and then staple the hepatic vein, and this is what we are left with in the end. So that's just to give you a brief idea of what a liver resection entails.
Irfan, we have 5 minutes more.
Okay, so far we've got 3 residents, and you can see they've had good exposure. We make sure they do gastrojejunostomy and cauterization. Our fellows do mostly hepatic jejunostomies, and they can do some pancreatic anastomosis. We also have some SIs who've completed their training from outside, and they've trying to become independent, and they've done quite well over here. In fact, they've actually done 5 independent pancreatic anastomosis, which were low risk, of course, and some liver resections. So looking at their outcomes, their R naught resection margin was 100%. That's better than mine. Their pancreatic leak rate is 0. That's better than mine. And the bile leak was 2. And we had the patients did okay, and they went home. But overall, their complication rates are really good. So we're providing good numbers, good training with not much complications for the patients. I'm just going to leave you with this 1-minute video of a laparoscopic liver resection that we did. Here we are dividing the falciform ligament, and then we're separating the liver from the anterior abdominal wall by dividing the falciform ligament. And then we divide the left triangular ligament that mobilizes the liver. And then we divide the coronary ligament. You can see the heart pumping away up there. That's just the diaphragm up here. And that mobilizes the liver for us. Once that happens, we flip the liver over. And by doing that, we get access to the posterior part of the liver. And you can see the lesion here that we wanted to take away. And we found an accessory hepatic artery, which we clipped and divided. Here we go. And after that, you use special equipment called CUSA, which is the Cavitron ultrasonic aspirator, and the ultrasound to make sure we've got the right location for the tumor. Then we divide the liver, and then we use a stapler gun to divide the inflow of the left portal pedicle. And that basically leaves the specimen hanging by a small hepatic vein, which we divide with a stapler in the end, like we are doing right now. And by doing that, the specimen comes off the liver, and the liver is taken out by a small incision. Now, I would like to take a credit for this, but this is not me doing the operation. It's actually one of our trainees who's done this operation, skin to skin, and she's come through our training program to be able to do this. Now, basically, this shows that with the right case selection and training program, complicated hepatobiliary surgery can be provided in a dedicated unit, and training is possible. It's a right of our trainees, and we owe it to our patients so that we train the future generation of our surgeons correctly. With that, I'll come to the end of my talk. Thank you very much.
Thank you very much, Dr. Irfan. It was very wonderful talk and gave an insight to the training program at Shaukat Khanum Hospital and the service that we are doing for our oncology patients. So we just have 1 minute left. So maybe we can take one. There is one question that I have, specially directed at you. If you want, I can take it now, or we can take the questions at the end.
We can take. What I might just say is, we plan on having a standalone HPB fellowship in the future, and if anybody wants to get trained in hepatobiliary surgery, please do come to us, because we will train you.
I think that was the main question that they were asking, that what is the path for this. So we'll take the other questions at the rest in our Q&A session. So moving on to our next presenter, I would like to introduce Professor Amjad Parvez Cheema. I'm sure that most of our participants are, and anybody who's interested in colorectal surgery or colorectal cancers is well aware of Professor Amjad Cheema's contributions in colorectal surgery. He's the pioneer of robotic surgery, and he has been very helpful in developing laparoscopic surgeries and promoting. He's a proctor for colorectal surgery. International level universities and hospitals. So Professor Amjad Cheema, thank you very much for joining us today, and I would hand over the podium to you for your presentation, please.
Well, I hope you can hear me. Good morning, everyone.
Yes, we can hear you clearly.
Okay, well, first of all, always a privilege and a pleasure being asked to come and speak to you. My special greetings to my friends in GI department who always have invited me. I'm actually staying at friend's place, so you would see some traffic. I'm trying to minimize it. So I start sharing my screen. I hope you'll be able to see this. So
Yeah.
are you able to see it?
Yes,
Okay.
we can see your slides. Thank you.
Okay. So the topic given to me was quite generic, and it was very difficult to sort of put all this strategy together. Although surgeons are very simple-minded people, but even with all simplicity, I felt that it's a bit difficult for us to simplify everything into 25-minute talk. So I'm going to focus mainly for rectal cancer and give you an idea, hopefully, of how we have evolved as surgeons. So when I talk of evolution in rectal cancer surgery, the colorectal surgeons would be well versed with two basic concepts. The total mesorectal excision concept came about 25, 30 years ago, where it became very apparent that if you do embryologically based operation, your local recurrence rate or local failure rate goes considerably down. Then in about last 15 years or so, we've been able to learn from the group, mainly in Stockholm, that perhaps taking extra tissue called extra elevator abdominoperineal resection would be able to reduce our local recurrence rate or improve the specimen quality, less perforation, less margin positivity. And in my lifetime, thankfully, we've been able to show that minimally invasive surgery have certainly improved short-term outcomes and shown oncological equivalence. And Shaukat Khanum group is well versed with this because they've been on this journey for the last sort of 15 years or so and doing more and more laparoscopically. So what are the important strategies? Somebody asked me, give us one answer or one slide that would teach me the gist of your talk. So this really is a gist of my talk. Anatomy holds the key. Anybody who wants one trick from someone like me doing laparoscopic or robotic surgery, I would tell you, seek anatomy. And anatomy to the surgeon is like a prophet to a religion. We also need help from other colleagues. I always ask people around me that your role is to make me look better. And radiology, really, a good radiologist who can read MRI scan are your eyes before you actually go and operate. You also need a very friendly pathologist in your MDT who is going to give you constructive criticism on quality of your specimen, but also keep your feet fixed to the ground, because we surgeons like to think that we are doing the extension of God's work. But the problem is we are only human and we make mistakes like most of the humans would do. So pathology to me really is a gatekeeping mechanism of keep reminding us that we are not there yet. And of course, when problems do happen, you need excellent MDT backup from your oncology colleague, from your specialist nurses, from your genetics groups, to actually give you an idea. So you could see that although the talk title sort of says surgical strategies, but you need a lot of allied care, healthcare workers' help actually to make it worthwhile. Now, is laparoscopy a tool or religion? So I'm going to focus my talk now on MIS surgery, because that's where the surgical strategies of surgeons have evolved in the last 20, 25 years. Now, in Pakistan, increasingly, people are doing more and more laparoscopic work, and you also have got a lot of WhatsApp group in the country. And I have been enrolled into some of these WhatsApp group without knowing who is enrolling me. So often I get pictures sent to me as a matter of appraisal to say, what do you think of this? This is one of the WhatsApp group, anonymous WhatsApp group, which I've got no idea who the surgeon is. And they asked me that, what do I think of this? This is their first abdominoperineal resections in the district they have done, and they were very proud of it. And surgeons who are sitting in the audience or in front of their computer machines would know that perhaps it all looks okay from outside, except that the stoma is a bit lateral. This is abdominoperineal resection, permanent stoma. And I sort of said, this is what my comment looking at this picture is, but I would very much like to see the specimen that you have removed, because to me, as an oncology surgeon, this is where the goalpost is. And most of you who are surgeons would agree that when this picture was sent to me, you could argue that this is perhaps slightly suboptimal. So this is really an emphasis of my talk. If young surgeons or budding surgeons are sitting out there trying to learn this skill, don't learn it as a religion, adopt it as a tool. Anatomy is a religion, and cancer is something that you're trying to cure. So oncology based with embryology holds the key. So this is no good if you ask patient what matters to them. Is it a nice car that mattered to the last lady? Answer is no. We patients are interested in coming to hospital and leaving hospital without their cancer, without complications. We increasingly are not only interested in living longer as a species, but we want to live better. So quality of life have become a huge influence in how we deliver cancer care as a surgeons. Organ preservation, function preservation is a key now. So MIS rectal cancer surgery offer precision, low conversion rate, access to difficult area of narrow pelvis, better preservation of urogenital function, and better short-term outcome, particularly in high-risk group patients. And I genuinely believe, following on from the talk from Irfan, the previous speaker, that it provide an excellent platform to teach and train people, because audiovisual reinforcement is so much better when it is on high definition and 3D view. But the problem is, laparoscopy or MIS surgery have been seen as a threat to change by our open surgical colleagues. Although there have been a number of trials in the West, cost study, color study, classic study done in UK, where I work, and short-term outcome showing that laparoscopy is better in terms of short-term outcome, and oncologically it is safe. But why it should be any different? Because the biology of the cancer has not changed. The anatomy of Homo sapien have not changed for the last 200,000 years at least. And it's not going to change in a hurry. If you look at colorectal practice in England, this is slightly older slide, I must confess, but this is hospital-acquired data, HAS data. You could see that from 2003, the laparoscopic intervention rate for colon and rectal cancer is about 55%. Now it has gone up to 65%. But this is both colon and rectum. If you separate rectums from those, then the numbers go drastically down. Why rectum is so much different? Surgeons would know this regardless of lap or regardless of open technique. Exposure is a problem. A male pelvis with high BMI is a problem. And then there is a lot of other contributing factors like radiation, low tumor placement, and the peer pressure that adds to the challenge. I'm just going to run past two studies which were published in recent time, looking at quality of specimen operated laparoscopically and compared it to open surgery, showing that laparoscopy is inferior in terms of specimen quality. This is a Australian and New Zealand trial called a la carte study showing the same. Similar study at the same time was done in US. This is SKCS study, and it shows exactly the same thing. But the problem really is the devil between the details, as you call it. If you look here in lap group, 12% CRM positivity rate and 15.5% of tumor perforation rate or rectal perforation rate during the procedure. That's quite high. If I have a rectal perforation rate of that high, my MDT would stop me doing laparoscopy. So is laparoscopy all that bad based on level 1 clinical evidence, based on RCT? The problem is some do it better than others. And people who do it better than others are people who have standardized their operative technique and who have subspecialist centers with very high volume, like one in Shaukat Khanum Hospital in Lahore. They do large volume of surgery. It is standardized operative technique, and they do it day in and day out. So what are the likelihood of their clinical outcome? Their clinical outcome would be comparative and competitive to any high standard of practice anywhere in the world. This is Korean study, which is Korean trial, internationally done, fantastic trial, very well designed study. Nobody lost to follow up, looking at locally advanced mid to low rectal cancer after neoadjuvant chemoradiotherapy, comparing lap with open group. Conversion rate is 1%, CRM positivity rate is 3% in lap group. They look at equivalent disease-free survival showing between the two group, overall survival exactly the same, and similar local recurrence in very small single figures. So it is possible to do this. When we looked at our own practice from Portsmouth at the time where I was, we looked at high risk group patients and we compared them to open surgery, lap group compared with open surgery. This is the data from those. So when high risk meant people who are 80 and above, ASA grade 3, preoperative radiotherapy, T4 tumor, and BMI of more than 30. So even in those high risk subgroup of patients, we were able to demonstrate that laparoscopy was associated with less mortality, less median length of stay, rate of complication requiring reoperation was smaller compared to open surgery, and so forth. So you could see that even in those subset of patients, it was possible to do it. But the key really is to how you standardize your operative technique and how people are able to demonstrate this technique over and over again. This is my own practice looking at laparoscopic approach to rectal cancer surgery. Data published recently, I think it was published last year, 2019. We looked at 5-year survival. This is consecutive patient, 82, 83%, stage by stage survival, very, very respectable as you would expect. And when you look at procedure done by me or supervised by me to 3 fellows, this is what Irfan was showing you, no difference in terms of clinical outcome, R0 resection, major complication. So although I felt for a very long time that I was something very special, this is to my disappointment that I'm no different to any other trainer. Anybody could do this operation if they are taught in a very structured way. So what does the structured way look like? So this is just an example of how the laparoscopy sort of evolved. On the right side or one side is the trainees being taken through start of the TME surgery. This is done in Belgrade in one of the Serbian national program where I go and teach. And then a similar approach being adopted going further into the anatomy. So if you are able to see this on your screen, you would realize that although the tools become slightly different, this is harmonic scalper, this is hook monopolar diathermy, but the anatomy remains the same. And you use the tool to your appropriate advantage. Brendan Moran used to say to me when I was a trainee, trying to show him the laparoscopic technique with fancy tool, that a fool remains the fool, or they say a fool is a fool even with the tool. So I think it's a key thing to remember. Similar thing applies here. If you look medial to lateral dissection, what you're following is this white line here. It's a speed up video, so you might not be able to appreciate this, but this is the idea that you are exploring anatomy. You are redefining anatomy. This is pelvis now. Remember, this is laparoscopy I'm showing you, straight sticks, so no 3D view. This is anterior dissection behind the Denovellius fascia or outside the Denovellius fascia, left nerve here. The surgeons have more interest than medical oncologists, I guess. But the idea remains the same. You explore anatomy with a tool that have been given to you. Can robot improve this? So this is where the marginal gain theory come in, that when you become good at something, you are given a better tool. Are you able to show us the marginal gain? But the context doesn't change. The technique has to be standardized. We have shown in our data that robotic surgery is associated with better nerve preservation in sexually active males. We also have shown that it is shown better clinical outcome for obese patient, particularly for short-term outcome. This is BMI of 35 and above in our group. And again, the similar theme was revisited with high-risk group to demonstrate that robotic surgery was associated with higher sphincter preservation, reduced blood loss, better conversion rate, and shorter operative time. This is Sohan Kim's data, which is showing that robotic surgery is associated with better long-term survival. Now, this is an isolated study that he's done, and that needs to be reproduced. But this is something to look at very, very closely. It is all underpinned by 2 words, standardization and structured training. The same theme apply over and over again. Even within the standardization concept, we have standardized the operative step even within the operation. This is splenic flexure mobilization. This is how we do this robotically, how we have published it, and this is how it is being taught. It is not only just the rectum, it's the exploration of the anatomy, like I said. This is medial to lateral dissection in front of your left kidney fascia. You could see, although the tool become different, but the anatomy has not changed. For me to be able to demonstrate this anatomy, I have to patiently, painstakingly demonstrate this. I have to leave it how I have found it. If you are able to do this surgery with this meticulous care, that's a very good surgical strategy. Somebody asked me, what is the gist of the talk? This is the gist of the talk, really. This is again operation done for two different subset of patient, no radiation, obese guy with radiation, anterior dissection outside the adenovillous fascia using the tool. Different tool, but anatomy is exactly the same. This is the focus of my talk. Again, you could see the adenovillous fascia being divided at this level now because the tumor is posterior. You want to go behind this seminal vesicle in the front. Different demographic of the patient, obese guy, same tool, dividing the fascia now at the edge here. Just the edge of the fascia is being divided to demonstrate. This is the neurovascular bundle, which we often make bleed and people get sexual dysfunction effectively. It really doesn't matter where you do it, whether this is Lisbon, this is done in a Congress, this is done in another Congress in Karachi. This is Dr. Amjad Siraj Group's Colocon meeting. They ask us to come and operate every year. Although it is two different geographical location, it's rectal cancer in both places. It's the same robot, it's the same surgeon, it's the same anatomy. Why it should be any different? So people are able to demonstrate this without fail. This is here in Doha, where I come and work now along with my European commitment. This is a group here. This is from last week, a locally advanced tumor, anterior tumor invading the uterus, under call on MRI scan because they said it might be a butting, not too sure. And she ended up with a TME with en-bloc ureteric, en-bloc uterus, en-bloc hysterectomy with bilateral salpingoophorectomy. So the operation, anatomy, the organ coming in, the thought process of how you do it does not change just because I certainly have a robot in my hand. I really need to follow the same principle. Of course, you can ask your gynae colleagues to help, but if you do oncology and if you do a lot of that, you would realize that you could do this very, very safely using this tool. The posterior dissection plane was created first because no point going here. You go past much further along where there is no cancer and then take the both round ligaments, ovarian vessels, and then uterine arteries under vision in the clips. This is the left ureter come very, very close, which the gynae colleagues would appreciate more than me. This is the uterine vessels coming in now. And I could just ask my assistant to clip under supervision in the very close sort of views. And once you've taken the vessels, then you go further, have a swab on a stick in the vagina, and you can cut right over it, distal to the vagina, distal to the uterine body, the cervix effectively. There you are, you open the vagina now with the gauze sitting there, and then all you do is to do the back wall and go parallel to the specimen, and then you can divide the specimen using a robotic stapling device, just like that. And then you close the vagina after you've delivered the specimen and do the anastomosis. So it is possible to do that. Obese patient, low tumor, how does tool help? You would see big guy, close the tube, do endoscopy, do rectal washout, make sure you are distal to the tumor, two firing of the stapler the same way, empty pelvis, intact presacral fascia, and a very good specimen as you would expect to see. You could see the buttocks. This is a nice, completely intact specimen. The idea really is, I'm finishing off with 2 slides now. The idea really is that this is the end post. This is the end game. No matter where you operate, no matter which way you operate, it is a specimen-oriented surgery. This is what you seek to take out of the patient and leave anatomical intact layer behind. Training landscape have changed, thankfully. This is open surgery, 1970 Texas, cardiac bypass. Now this is robotics now. And there might also be a vein a bit further lateral. Done remotely. More surgeons are doing it with a 5G technique. So my conclusion really is that the surgical strategy to improve our outcome is anatomical. The anatomy holds the key for us. Standardization of operative technique remains the underpinning factor to improve our results. And there is no such thing as one big maneuver that I would do to improve my outcome. It is attention to minor details that makes the difference. And remember, there is no point me doing it so well that it dies with me. As Irfan repeatedly said, we have a duty to be able to reproduce what we could do and improve by next set of people. Gains are marginal and they come with purposeful practice. I'm grateful for the opportunity. Thank you very much for listening to me. I'm happy to take any questions.
Thank you very much, Prof. This was very, very informative and gave us a new insight into how the landscape of surgery is changing, mainly in colorectal surgeries. Can we take the question answers at the end, if that's okay with you? Are you staying with us till the end?
Yeah, I am. I'm actually staying with my colleague, Dr. Abu Rada, and who would be talking to you fairly soon because
Okay,
I'm.
so then we'll keep the question answers for the end so that we can have a good panel discussion. Moving
Excellent.
on to our last talk for the session. Uh, we all know that role of multidisciplinary team in cancer care has been advocated for a very, very long time. And what better specialty than hepatobiliary and GI cancers, where each team member whether plays a very integral role and has a key element to perform in care of these cancer patients, and provide them, instead of a fragmented approach, a coordinated care which improves the not only the patient satisfaction but their outcome as well. Whether it's a gastroenterologist with the interventional skills, it's a pathologist, medical oncologist, surgical oncologist, or above all, a radiation oncologist. So taking this topic forward, I would like to invite Dr. Muhammad Husni Abunanda from, he's a senior consultant oncologist, colorectal surgeon at Hamad Medical Corporation, Qatar, and he will be talking about how can we improve the outcomes of cancer treatment by multidisciplinary teams. Thank you very much, Dr. Muhammad Husni, for joining us and taking your time out. I'm handing over the session to you for your talk, please.
Good morning, and I'm very pleased to be in joining such a distinguished group of people, and I'm very honored to be on your conference.
Thank you very much for taking your time out. Thank you very much.
So
There.
yeah, this is actually new to me, but bear with me for a minute, and I hope that I will be able to just give you a little talk about what we have done in Qatar for developing of the colorectal MDT in the state of Qatar. So
Next one. You can bring it down. It would just give you an idea here. You can move it forward.
this one.
Yeah. Yeah.
Okay. Here in the state of Qatar, we have general hospitals really to start with, and we always had excellent, talented surgeons to work in the Department of General Surgery. But as you know, to improve services and to improve outcomes, we really needed to have committed people to do a specific type of surgery, which is the specialties that we all aspire to. So as you all know, all surgeons know, colorectal surgery will constitute a major part of general surgical practice. And because of that, we started to wanted to develop a unit that will serve the population of Qatar in colorectal practice. Now, it is really a very difficult thing to get general surgeons to stick to one type of a specialty. As we all know, when we started this practice, everybody wanted to do everything. And in spite of data suggesting that when you get a specialty, you get better outcomes. So to start that, we in the year 2007, a small unit of colorectal surgery was set up, which that contained only one surgeon. We were working in the Department of General Surgery, and we started to sort of concentrate those patients that really needed a specific specialty into this surgeon. And it actually evolved over a period of 10 years to have 5 qualified surgeons to do colorectal surgery as per qualification. We also have managed to do a fellowship program that actually managed to graduate two surgeons, and they were working, and now currently they're working with us in the department of, or in the unit of colorectal surgery. The colorectal unit covers actually a wide range of services, which include, of course, colon and rectum malignancies, but it also involved in the treatment of other benign conditions, inflammatory bowel disease, and anal conditions. So it's not only a colorectal cancer that we are taking care of, but we are taking care of most of colorectal practice. But of course, colorectal cancer is one of the most important topics that we cover in colorectal surgery, and it's very, very important that we, as previous surgeons or previous speakers have mentioned, that improvement in the outcome of colorectal cancer is extremely important. Traditionally, general surgery units were performing these, but there was no structured cooperation between the concerted specialties that will be involved in the treatment of colorectal cancer. In the year 2007, we have, myself and a colleague from oncology have developed what an initiative on a personal level to form an official MDT. But that, of course, needed enforcement from the hospital, and it needed also enforcement from the healthcare providers. And managed in the year 2011 to form an official GI cancer MDT, with colorectal cancer treatment being a major part of this group. Everybody in the audience would probably know that the MDT members would cover every aspect of the treatment of colorectal cancer, which include multi-specialties, colorectal cancer surgeons, of course, oncologists, of course, and all other concerned specialties like radiation oncologists, gastroenterologists, pathologists, radiologists, and also would include MDD coordinators and patient coordinators, and a lot of other services like stomach care nurses and the clinical nurses specialists. You know, when you try and set up something like that, you should cover everything. And when you have a very busy hospital like ours, which cares for almost 90% of patients in the country, you would have a very busy services all around you. And if you do not have special pathways for these patients, they get involved in the busy center, and then it is extremely difficult to have everything done in time. As you can see from this slide, that our services has improved over time, and the number of cases that we are caring for has increased over time. Now, this is the group that we're working with, and this is just at the entrance of the hospital. And you can see that it is growing with the younger generation and older people around. Now, the major improvement that we have achieved using developing this MDT was actually to coordinate treatment plans for these patients and make it patient specific. And this is can only done by having the MDT. And we have managed to enforce a rule that only emergency surgeries would be done without MDT decision, but the rest of surgeries would all have to be done after the patient is discussed in MDT. But this is not only the thing, but why we want to have this MDT discussion is that to have a standardized treatment guidelines for these patients, and this can only be done by MDT, and this has actually made us to develop MDT guidelines or cancer treatment guidelines, and we have managed to do that for the state of Qatar in the year 2016. But to improve outcome, we also have to introduce new surgical techniques and laparoscopic resections and robotic resections. We have just listened to Professor Amjad Darwish a while ago, and he was actually one of the experts that have helped in developing these techniques for us, and our numbers now would be about almost 90% of patients being done with minimal invasive surgery. As I said, it's a busy hospital, and one major improvement in our services was the development of a clear and fast-track patient pathways. And this is done through approving all of these steps by the healthcare provider leadership. There's so many aspects of this treatments and support for these patients, and this is done also during done through training of specialties, the needed specialties for these patients, and the development of clinical nurses specialists and stomach care nurses locally is a very important thing. As everybody knows, these are very hard people to get to your working force, as this is wanted all over the world. Also, clinical data is also extremely important, as you want to know all what you have been doing, and you audit your work to try and improve it. This can only be done through concentrating those patients into a specific group, and then in that specific group you can get the data, and you can improve your services to know what exactly you are doing. The major thing that I would stress on here is that we have managed to maintain good standards through restricting cancer surgeries for the colorectal surgeons that we have here in Qatar. It's not only cancer, but we also have participated with our colleagues from the gastroenterology department to develop another MDT that would look after inflammatory bowel disease, those patients who have Crohn's disease and ulcerative colitis. Excuse me. Those patients are also have very complicated, retracted clinical scenarios, and they need special care, just as a cancer patient would need. So a special MDT was also developed for these type of patients, with guidelines also developed. We have also participated in developing a screening program for the state of Qatar, and this screening program has been set in the year 2016, started in the year 2016. And it has actually increased the number of cases that we are operating upon right now, and reduced the stage of the cases that we are seeing right now. It's only about 3 to 4 years now since it has developed, but it has actually shown an improvement in the stage of patients that we actually see. This is also done through the national level, and it is in place right now. We also look in the future to develop a pelvic floor unit so that it will help in general our colorectal services. There is one success story regarding this department, which is the development of a colorectal symposium that first was held in the year 2012, and it since then we have reached now the sixth symposium in last year, but unfortunately we're supposed to have one now in this year, and with the COVID situation, it has been postponed to next year. So I hope that in the year 2021 we will be able to have our seventh, and I would also hope that we would have some of your distinguished surgeons and oncologists to join us in this meeting. It has started in 2012 with about 50 participants and 2 international speakers. Now in the year 2019, we have more than 500 participating and about 25 from international speakers. We have been in this conference coordinating with different subspecialties, and we have joint meetings with the gastroenterology and hepatobiliary, oncology, radiology, and all other subspecialties. You can probably recognize some of the people in the picture, and Professor Amjad Ayman Agha, and the Bible of colorectal surgery here in the picture. Some other people who have joined, maybe you've recognized some of them. This is the 4th conference that we had. And this is a picture of the conference that the one before the last. And this is the last conference that we had in the year 2019. Hopefully that we will be able to have one on 2021. We get wide range of speakers from Europe, North America, Brazil, all the way to people from all over the world. This is a very just an introduction of the way we do our work, and in conclusion, we developed a specialist colorectal unit that required infrastructure and expertise. Development of an MDT brought about the streamlining of services in colorectal cancer in this country. We have all elective colorectal cancer resections being performed at Hamad General Hospital now, and all colorectal cancers are discussed and documented at MDT. Thank you very much for listening to me, and hopefully we will see you in Doha in the next year.
So thank you very much. It was nice to know that another center in Qatar is working that great, and we are having this regular colorectal surgical meetings and national conferences over there. So now we'll move on to question and answers. We have a couple of questions from the panelists. For the panelists, Dr. Irfan, you want to go first for the questions?
Yep. So there's a question here from Dr. Zakaria, who's a HPV surgeon in Lahore, and he's asked us if we use ICG testing for cirrhotic livers in HCC patients. So unfortunately, we do not have access to ICG in Pakistan. I don't think there's any it's available in Pakistan in the first place. We do use surrogate markers to assess the function of the liver. So we tend to go for portal vein pressure assessments. We look at volumetry, so we do volumetry. And if we really need to do some sort of assessment of the liver function, then we do the HIDA scan, which we haven't really had to use at the moment. So the answer is no, we don't have access to ICG, but we have alternatives, which some papers might suggest might be better than ICG testing for liver cirrhosis.
Thank you very much. Yeah. Sorry, please.
Should I ask the next question from Prof?
Yeah.
So Prof, there's a question for you from Dr. Irfan Islam, and his question is whether you will be able to make any comments on the availability of robotic surgery in Pakistan and how long will it take? I think you get asked this question quite a lot.
Yeah, I'm surprised he's still asking this, because he's been saying this in Lisbon and England while he worked with me. Well, I think the short answer is that this is where the goalpost is going to move. As we all know that historically for the last 20 years, there was a single provider having a complete monopoly on the market. And currently, the politics don't sit very well with that single provider with Pakistan. We have 2 robotic systems, one in Qatar Hospital, as you know, in Karachi, and the other one is Civil Hospital, or SIUT now, where it has been moved. And because of the logistics and people not paying their bills, they have disconnected the contract. So they're not selling any more robotic system in Pakistan based on that principle. But next year you would have at least 6 different providers providing the new machines doing it. I think there is a Chinese version coming in, 2 of them, which I'm sure Pakistan would look very keenly and favorably on. So it would be only matter of time. It's not a question of whether it would become available. It would become available. The question is when, and answer is very, very shortly.
Okay, so I suppose the main concern in this part of the world is the cost. So we just have to see how cost effective the Chinese model is going to be and how robust it's going to be. I suppose with everything else that they've made, they've kind of come quite technologically advanced. But I think cost is going to be the main factor here. And then obviously after that, the second thing that's going to come is going to be the training. So the second question I have here for you, which is kind of ties into this one, is structured laparoscopic curriculum in low to middle income countries from Dr. A. Razak. Your thoughts on structured curriculum?
Yeah, I think this is no different. For example, with my limited experience of going around the world, I have a huge privilege of visiting different part of the world with different skill set, for example, or resources available. Places like Iran or Eastern European haven't got that much of a resources invested into teaching and training. So, and you are able to reproduce this. The key really is the interest or the commitment from stakeholder in this process. You mentioned in a slide there is bit that the trainer have to do, but there is a lot of bit that the trainees have to do. So, for example, professional bodies like colleges, Pakistan College of Surgeons, for example, or Pakistan Surgical Society, whatever you want to call it. I always call Shaukat Khanum Hospital as what you call a goalpost, and say maybe this should be a program run by Shaukat Khanum, for example, a national initiative. The idea really is that we could structure and you could deliver what I call hub and spoke model. So you develop 4, 6, 8 regional centers and bring them to the level of being trainer, so they could train the districts. You could not go around and train everybody in the world because of resource scarcity and infrastructure of time difficulties, but you could certainly train 4 or 6 centers to the level where you think the benchmark should be. And that doesn't require a lot of resources. Pakistan hopefully have got monopolar diathermy. They have a diathermy hook, and usually there is a backup generator even if the electricity goes. So you are able to demonstrate all of this, in a very precise anatomical way. So I don't think so that is difficult. The difficulty is our prejudice and resistance to change. Because if I am a well-established open surgeon, I want to train Irfan Kabir 20 miles from me. I am fearing that he's going to take my livelihood away. That's the problem. That needs to change rather than a new curriculum signed by American society or British society and all these societies. That's my non-political answer.
And yeah, it was quite political as well, but yes, we will take it as non-political. So there is just another question from a radiation oncologist resident, I think, and they're trying to ask that now we are moving more towards short course radiotherapy. So is when you're operating with a robotic approach, do you think that there's difference in technique when you operate with a robot, and what are the late complications in post-operatively in short course radiotherapy?
All right. So maybe I'll ask Mohammed to comment as well,
Yep.
because
Yeah.
he's been here and he's developed this. And
Okay.
short time I've been with him, I have seen this huge discussion at MDT, whether this is short course, whether this is long course, when you would operate. And then I'll give you my version. What do you think, Mohammed? Does radiation adds to the challenge? Do we change our technique laparoscopically or robotically?
The short answer is no, because the anatomy doesn't change, and the cancer doesn't change. Now, if you want me to answer this question on a personal preference, I do not like to operate on patients with a short course radiotherapy. The field may be a little difficult, and then you are also restricted in the time that you want to do the operation, and which sometimes in a busy hospital is not possible. Sometimes you get problems with bed to admit patients. Sometimes you have other commitments that you cannot organize those patients in your operating list. If you have all the facility, I don't think that that this would make any difference to the operation. Now, regarding oncology, this may be something another question that we need to discuss, because there are other issues
Yeah.
related to oncology.
So we increasingly have moved away from short course and operating next week, for example. You know, what
Yeah.
we do now at the back of CRO7 trial, certainly from UK, is you give short course because of reduced toxicity, for example, but you operate and you treat them just like long course. You operate 8, 12, 12 weeks, preferably, you know, looking at the response rate and so forth. So it's almost like short course and delay, right?
Yeah.
Rather than operating the next week. As Mohammed said, the problem is the logistics of if you can fit those people in the next week. There is no need for that. The morbidity, the operative technique, the operative steps, they remain the same, even with lap, robotic, whether short course or long course. That doesn't change at all.
Yeah, so exactly. This year we have also moved to the total neoadjuvant therapy, which showed that short course followed by chemotherapy and a delayed surgery adds some advantage and progression-free survival in these patients. So
That's
the traditional fear of giving higher dose per fraction and ending up in more fibrosis, I think we have crossed that curve and we are doing better in that. So Dr. Irfan, there is another question if you would like to take that, please.
There's a question here. There's one for, I think we've got two colorectal surgeons here. So there's a question is from Dr. Razak again, and he's asking whether there's any advantage of transanal TME in comparison to transabdominal TME.
Yeah. This is, we both will have a view. Well, I'll let Mohammed go first and then I'll give you my version.
Well, personally, I have no experience in TME. My view on this is that difficult cases are going to continue to be difficult cases. I do not want to comment on something that I have not operated or I'm not used myself. From the videos I have seen and from the surgeons that I've spoken to, it has a very steep learning curve. Problems can really arise, and it is very, very difficult to deal with. A patient with a BMI of 45 is going to be difficult whatever approach that you're going to take with him. So I still think it needs time, and if you can get with a robot the views that Dr. Amjad or Professor Amjad Barbiz have shown us, I don't think that there is a need for the TATME, but that's only a personal opinion.
Right. I think the other way of looking at it is this, that why do we need to look at different ways of doing rectal cancer, either with robot or TATME, for example, or giving TNT approach, you know, total neoadjuvant therapy and getting wait and watch, for example, difficult tumor if they show clinical response. The answer to that is very simple because it is a difficult problem that we're trying to deal with. And TATME came few years ago as something which is a new fashion. We surgeons like to be in a new fashion. You know, laparoscopy was a fashion many years ago. Robot is a fashion now, for example. So if you don't do anything different, then you're not sexy enough as a surgeon. You know, you can't go to meeting and, you know, have a social podium effectively. So that was the reason people were being pushed. And likewise for robotics, even whether we are good or bad at it, because the hospital have bought it and I need to be shown to be doing it. So people start sort of having a little go. Now the data is coming out for TATME in Europe, certainly showing higher than normal expected local recurrence rate. And it's not just the recurrence rate, it's the pattern of local recurrence, which is radial recurrence on the pelvic side wall. Because remember, the surgeons would know it, that this is done from the bottom up using a high speed gas insufflation. So Norway data showed that nationwide they had a local recurrence rate of 12% at the end of first year. So they have put a moratorium to it. Danish followed them. ACP GBI in England have also come up with what they call caution, and they have stopped asking surgeons to stop doing it outside the trial setting. So it's like any other thing. You know, robots should not be any exception at all. It should be under scrutiny, and we need to demonstrate that this is safe, and it is, if not better, at least at par of our current existing practice. So people have tried it. It's a different anatomy. As Mohammed said, people learn by mistake. But the problem is you learn at the expense of patient. while you are learning these with like urethral injuries. We hardly ever have a urethra injury coming from above. Anatomy is much more familiar to us coming from the pelvic approach, abdominal approach, for example. So I think the short answer is learn one skill set to which is applicable to vast majority of your patients, so you can reproduce good clinical outcome, and then have get out clause rather than saying I do a bit of this, I do a bit of that, and then you're not good at anything in particular.
So I'll just add my 2 pence to that. I'm not a colorectal trainee, but I did get involved with TATMEs in Oxford when they were doing them there, and I was never a fan. I always had a bad back at the end of it. So it's my 2 pence in there.
Yeah, just one comment regarding the local recurrences that we are seeing now. If you all remember, when laparoscopy started, there was this notion of having local recurrences higher in laparoscopic patients, and this is actually been shown in some of the trials in the initial stages of laparoscopic surgery. So this may change with better training and better instruments and things like that. But the problem remains the same. Why do you want to do this? The advantages in what they advocate as an advantage is in those patients who are very difficult to approach from above. Now, these patients are going to still be very difficult to approach from below. So that is the problem. And when you need these skills, you are going to use them in a very, very difficult situation. It's like Amjad has said, it's good to have it as part of your armamentarium, but to be the standard of care for those patients, I have my doubts about that.
Right. I'm going to ask one last question, and then I'll leave the very last question to Dr. Tabinda. So here's a question, and it's about the role of ICG in colorectal surgery for anastomosis. I'm just going to say it's not available in Pakistan ICG, so I'm not quite sure what we can do about it here, but I'll leave the question up to you to answer.
Right. It's one of those things that, the hammer looking for nail. So you have a technology now that might help us. So traditionally speaking, what we used to do is cut up to the level of marginal artery and then see a pulsatile blood flow. This was the conventional method, still applicable. Even ICG is not available in Pakistan, but I am pretty sure your anastomotic leak rates are well within the norms of internationally published data. So that gives you an answer in its whole self. But I'll give you a subset. For example, it is driven really by litigation culture. It is far more useful and being used in US, for example, where you have to document that you have done everything possible to anastomose a well-perfused bowel, prevent the leak. So we use them routinely. In my limited experience of using it for a few years, hardly ever you have to revise your what you call anastomotic line to do more proximal resection, because you were about to anastomose an ischemic part, although certain enthusiasts have published 3 to 7% or 10% revision, depending upon who you talk to. It probably give you, we all have been there when we have done the usual operation. You think probably the blood supply is probably okay, and the patient is diabetic, obese, small arteries. Then you need something to give you that sort of moral high ground to say it is all green, it looks well perfused, so I've done everything that I can do. So diabetics, atherosclerotic patient, a borderline clinical assessment. And if you have this tool, it would give you that much confidence in anastomosing it. But remember, that is not the only factor that leads to anastomotic leak rate. It could be very well perfused, but it could be under a lot of tension. It could have a mechanical failure at the staple line. So it's a multifactorial thing.
Okay. Yeah. So there are few participants who are actually trying to welcome, and they are really pleased that both of you are here and you have joined us as a panelist. So thank you very much. I'll convey your regards to Professor Amjad. So there's another question from one of the resident participants, and they are asking that whether we have an online resource where we can learn this entire thing in one go. I think they are looking for some shortcuts or in robotic surgery and TME surgery. So is there any online resource for them?
Yeah, of course. We are running. In this pandemic, this has become very obvious because you can't travel and people ask you for that. We run lots of teaching training webinars on a regular basis. There is a program which would be launched fairly soon from Hamad, for example. And this is not based on Hamad trainees. It's internationally available. It's free of charge. People can join in. So resources are available. The group in Shaukat Khanum, people who've been with me previously, they get automatic links sent to them. There are a lot of Russian program being run through us. So this is a resource that is available to all trainees sitting in every districts of Pakistan. That really is not an excuse that you sit in Swat and you have no access to facilities in Lahore or in Doha. We've become a much smaller word, much more scared word. So we are feeling much more secure in front of our laptops rather than getting onto the plane. It is available.
Can I add to that? I mean, we don't have any corona in Pakistan, so come to the Shaukat Khanum Hospital and we'll train you both in colorectal and HPV. So come and join us here.
Thank you. Thank you very much.
So that's a good advertisement at the end. And I think we are done with our questions. Thank you very much, Prof. Amjad, or Dr. Muhammad, Dr. Irfan, for taking your time out at this time early and during this difficult times and for this very informative and learned session. Thank you so much. And hope we'll see you next year when this pandemic is over and we are all back to our normal.
Inshallah.
Thank you very much. Thank you.
Bye-bye.